Today I'll be discussing a brief outline about screening, motor and sensory examination. Details will be covered in other sessions. Basically, there are 5 patterns of muscular weakness. One is the upper motor neuron type, that is a UMN problem, characterized by increase in the tone of hypotonia, hyporeflexia, and a pyramidal pattern of weakness. What do you mean by pyramidal pattern of weakness? If you observe a hemiplegic patient, you can see that the hand's shoulder is adducted, elbow is flexed, and wrist is flexed. Why it is so? There is increased tone of the adductors, or adductors are more powerful compared to abductors. The lower limbs exactly opposite. The legs are extended, knees are extended, foot is plantar flexed. This sort of pattern of weakness is called the pyramidal pattern of weakness. Second pattern is the lower motor neuron type of weakness. This is characterized by weakness, long-standing cases wasting, presence of fasciculation, hypotonia, and hyporeflexia. What is fasciculation? Fasciculations are contractions of individual motor unit. What is a motor unit? A single alpha motor neuron or its corresponding neuron in the cranial of the cranial nerves supplying the muscle fibers. For a single alpha motor neuron with the muscle fibers supplied with it is the lower motor neuron. Anything which is controlling the element is the UMN. So these are the basically 2 patterns. In addition, in UMN lesion, you will get an extensive plantar response, absence of superficial reflex like abdominals and cremasteric reflex. And remember, in UMN lesion, the acute phase, you can have hypotonia. Same way, human lesion long-standing cases can develop a disuse, wasting also. Then the pattern is that of muscle weakness. They are bilateral, symmetrical, long duration. Usually family history is also there. And the reflex loss and power loss usually go hand in hand. When there is significant muscle problem, muscle weakness, there is a decrease in the tone and the reflexes will also be sluggish. Then comes the neuromuscular junction. The typical example is the myasthenia, where you get a fatigable weakness. That is as there is a decremental pattern. That is when repeatedly do the work, the muscles are fatigued. This may be manifested in the history as diurnal variation. That is, evening patient is more weak compared to the morning hours. Ophthalmoplegia is a characteristic around 85 to 90% cases. It presents with the involvement of eye muscles presenting as ptosis, unilateral or bilateral, and various external ocular muscle weakness. And sensory loss is absent, no sensory loss. And the muscle tone can be decreased, and the reflexes will usually be normal. Then comes the psychiatric disease, conversion reaction. The tone is normal, reflexes are normal, no wasting, and the power, it is erratic. Sometimes it may be more weak, sometimes it is less weak, and sudden giving way. So that is, in a patient with a weakness, this sort of a sudden giving way will not be there. So these are some of the features. And all muscle weakness you grade on a scale. The normal power is grade 5. 4 is submaximal. So you can start with 0 means no movement. 1 is flickering a movement. 2 moves when the gravity is eliminated. 3 is moves against gravity. So suppose a patient is able to flex his hand like this is a grade 3 power. Gravity eliminated, that is this sort of movement. This is a gravity eliminated, that is a grade 2. And grade 4, slight movement against resistance. And grade 5 is normal power. Some people divide the grade 4 into 4 minus, 4 and 4 plus, depending upon the extent of weakness. That is, in 4 minus means slight movement against resistance, 4 moderate movement, and 4 plus means submaximal power only. The patient will not be able to resist. So we have discussed about the 5 patterns of weakness, and in the next session we'll go on to the inspection of the motor system. Stay tuned.